Hi guys, welcome to week 6. We are now into our chapters on cardiology. Keep in mind that this week and next week will be 2 lectures, both on cardiology, part 1, part 2. There is a lot to cardiology, the cardiac system. So it's just definitely easier to break it down into 2 different parts. And in this particular part 1, we're going to be doing a review of cardiac manifestations, like their symptoms, syncope, dyspnea, chest pain, that kind of thing. We're going to be reviewing hypertension, lipid management, metabolic syndrome, coronary artery disease, acute coronary syndrome, and heart failure. So we have about 106 slides to get through. This is a longer lecture than normal. So I am going to read through some of the slides faster than others because I don't really need to read them to you, as opposed to just kind of making sure I point out to you the important clinical pearls, as well as the things you really need to make sure you know for your boards. All right, so let's get started. Cardiology. So the first thing I wanted to do, I like to throw in some visual videos just to give us a quick refresher on the basics. Let's always bring it back to the basics when we're trying to think of things in terms of their pathophysiology of their disease process. It's always good to bring it back to the basics of how the organ actually functions. So let's look at how the heart works in 3D. Quick video, just a nice little reminder.
The natural gatekeeper for the heart, through which all the heart's electrical signals normally pass. The electrical signals then pass through the bundle of His to the Purkinje fibers, which cause the heart muscles to contract. There are many factors that contribute to proper heart function. Talk to your physician about your heart health and steps you can take to keep your heart healthy and strong.
Okay, again, just a really basic review of the function of the heart. So that's super helpful. I will tell you guys that when it came time for me to really grasp and memorize and really learn and understand the concept of the cardiac murmurs, I found that watching like 3D type YouTube videos pretty much over and over again until I grasped it was really the best way for me to understand the cardiac murmurs. Those are very hard if you're not consistently around them, where you're able to assess them in a patient and know, what you're trying to listen for. That can be very confusing at times when you're trying to memorize it for test taking purposes. So I will encourage you, when we do get to cardiac arrhythmias, to consider really looking up the YouTube videos and just really consistently playing them over and over again until you grasp them. And I will make sure to include those in my next lecture to give you some resources of good ones to use for review. Okay, so content. Let's review the common chief complaints. So, pretty consistently with all of these particular diagnoses, they all have pretty consistent chief complaints. So these are important to know for all of these particular diagnoses. So in terms of reviewing the common chief complaints, you're always going to have this differential diagnosis of considering hypertension, high cholesterol, acute coronary syndrome. Now remember, acute coronary syndrome is a broad umbrella word for angina and MI. So heart attacks and chest pain or chest discomfort fall under acute coronary syndrome, ACS. And then, of course, the diagnosis and management of heart failure. All of these particular chief complaints that we're about to discuss fall under these particular differential diagnoses. So just consider that. Remember, too, very important, that as a primary care provider, it is your responsibility to manage high blood pressure or hypertension, dyslipidemia, and cardiac disease. Obviously, when things start to progress and we get into the later stages, you definitely want to refer your patient to a cardiologist, or even in the beginning, just to get their feedback and their input and get a baseline and get them connected to a cardiologist, especially if you feel that the patient is likely to not make the appropriate lifestyle modifications, or you feel like they are going to be a complicated patient. That's when you definitely just want to go ahead and make that referral. But in the meantime, it is your role to keep their symptoms under control. Of course, the other cardiac, considerations you want to take into consideration when you are considering differential diagnosis is atrial fib, arrhythmia management, vascular and valvular disorders. But we will get to that more importantly, not only in the next lecture, but also in FNP 2. Okay, Basic chief complaint that you'll see, chest pain. You know, we want to make sure you remember there are certain diagnoses that you want to make sure you don't miss for chest pain. Now, remember, chest pain is a key symptom that when you're triaging a patient, whether they come into the ER or whether you're doing rounds in any particular specialty, if you hear a patient complaining of chest pain, you know that that's something that needs to be followed up with immediately. So in terms of differential diagnoses with chest pains, the things we want to consider would be MI, PE, aortic or thoracic aneurysm, pneumonia, pneumothorax, pericarditis, or an esophageal rupture. Chest pain. So remember, we have our gold standards. Healthy People 2020 stresses the need for lifestyle changes to reduce coronary heart disease related deaths. As we've mentioned before, chest pain differentials can also include pulmonary, GI, musculoskeletal, neuro, psych, and idiopathic causes. Psych being also anxiety. A lot of people will, you know, mistake an anxiety or panic attack with, you know, they associate it with chest pain. Chest pain that's associated with dyspnea, diaphoresis, sweating, nausea, dizziness are the most concerning in terms of associated symptoms with chest pain. So again, if you have a patient with chest pain who's complaining of shortness of breath, they are also sweating, they are nauseous, and they are dizzy, this is when you know that the likelihood is something is impending that is about to happen that would result in an emergency situation. So please contact 911 immediately. Cardiac chest pain presentation can vary greatly, especially in women. So keep in mind, chest pain in women can vary from the chest pain complaints in a man. A lot of the times women complain of chest pain, but they actually mistake it for GI issues or stomach pain. In terms of diagnostics, when you do have a patient with chest pain, the things you want to definitely consider ordering at minimum are an EKG. You may want to do a chest x-ray. You definitely want to do some cardiac labs. Make sure they're not having a heart attack. You want to do a CBC, a complete blood count, a metabolic profile, ESR, CRP, and an echocardiogram to look at the functioning of the heart. Okay, chest pain, consider and apply to practice. Consider from a medical legal perspective. If you are considering that the patient is having an MI, you want to send the patient to the emergency room for proper evaluation and diagnostics. Avoid evaluating from the office. Labs might take hours to days while the patient could be infarcting at home. Okay, so what does that mean? That means don't waste your time doing the blood work in your primary care office if you don't think you're going to get the results back within an hour. You know, you need what it's telling you here is the likelihood is with the labs where you send your blood work to in your primary care office, it may take hours to days before, you know, you actually can find out what's going on and the patient could have already had a heart attack. If you send a patient home and there is a negative outcome, the question might be, why didn't you transfer to the right level of care if you were truly considering an MI, as evidenced by ordering cardiac enzymes, doing an EKG, etc. So the moral of the story, just make sure you use good judgment when patients are presenting with chest pain, get to the proper level of care as needed. Okay, if anybody tells you they have chest pain and you're even questioning it, even 10%, 2%, don't hesitate, send them to the emergency room, okay? All right, here's your diagnostic reasoning algorithm when it comes to chest pain. So here we have chest pain. And this gives you the basics on, you know, how would you work it up? You know, so it depends on the location. Here is all about the location. Depending on where it's located exactly, it gives you more of a guide as to what the possibility of diagnosis or causative factor is likely. All right, so just look at this. So for instance, if the location of chest pain is over the lung area and the characteristics of the chest pain by the patient are cyanosis, dyspnea, or cough with hemoptysis, it's a sudden onset cough. Aggravating factors could include inspiration. Alleviating factors would be, you know, analgesics. That's, you want to key in and rule out PE. In terms of an MI, let's say the location of the chest pain is across the chest, may radiate to the jaw, neck, arms, or back. The characteristics of the chest pain could be pressure, burning, aching, tightness, may be accompanied by shortness of breath, diaphoresis, weakness, anxiety, or nausea. Sudden onset usually lasts half an hour to 2 hours. Aggravating factors include exertion and anxiety. Alleviating factors include morphine. Okay, these particular symptoms that you're being presented with, this in particular, you want to rule out an MI. Okay, So that's how you look at these algorithms. They're really helpful because they're very much evidence-based practice. You know, there's a lot of research that goes behind these type of algorithms. So you definitely want to use them when you can. Okay, another chief complaint, syncope. Syncope, what is syncope? It's an abrupt loss of consciousness. It's a discrete episode. It usually lasts a few minutes. It's like somebody just is there and all of a sudden they're gone. They pass out. You know, implied pathology is usually there's a decrease in the cerebral blood flow caused by a marked decrease in cardiac output. You must consider, is this cardiac related, like an arrhythmia, or is it neurological related, like a CVA? Both of these things are emergency situations that need to be followed up with, okay? Is a vasovagal or cardioneurogenic syncope, which is a common etiology. Sometimes patients, when they're straining on the toilet, when they're having a bowel movement, they can have a vasovagal response, which can lead to syncope, a syncopal episode where they just randomly pass out. Non-cardiac causes could include fluid loss, dehydration, emotional stress. You know, sometimes people pass out when they're dehydrated. Pre-syncopal experience presents usually lightheadedness and weakness. So if you're questioning whether it was a cardiac, find out if prior to them having the syncopal episode, if they were experiencing lightheaded and weakness, because this could usually indicate more cardiac than anything. Is it preceded by exercise or exertion? Is it preceded by vertigo or spinning, which suggests an inner ear concern? Diagnostics, again, at minimum, this is the basic standard of care that we're giving right now, as opposed to just, you know, thinking outside of the box. These are the basic things you want to be ordering if your patient presents with syncopal episodes or episode. So you definitely want to do an EKG to rule out an arrhythmia. You may require home monitoring, like with a Holter. You want to do an echo to look for an outflow obstruction, like a faulty valve. You want to do a CBC to rule out anemia, metabolic profile, thyroid, electrolyte disorders, blood sugar, and their thyroid. Let's check their thyroid levels. You may want to do a CT with contrast or an MRI of the brain to rule out a CVA or other neurological event. So when you have a patient presenting with a syncopal episode, the other big thing you want to definitely consider, if there's not an emergency presenting, if they're not in acute distress, is a neurological exam. Okay, dyspnea, etiology. Is this, okay, so another chief complaint, dyspnea, shortness of breath. We want to think about the cause. Is it a cardiac cause of dyspnea or a respiratory dyspnea? So are we short of breath from our heart issue or our lung issue? New symptoms or an exacerbation of a known problem. So we need to find out, what's the history of this patient? Are they asthmatic or COPD? Is their COPD a new diagnosis? Is it acute or progressive? Same thing with the asthma. When was the last time they were hospitalized for an asthma attack? These are important questions to know because this will also dictate your treatment plan. So we also want to know about other symptoms with dyspnea or shortness of breath. Are they experiencing anything like orthopnea or paroxysmal nocturnal dyspnea? So remember, orthopnea is shortness of breath when in the supine position. So you always want to kind of say, how many pillows are you using at night? 2, 3, or do we find we need to increase, or you just can't even sleep lying on pillows? Now you have to sleep in your recliner chair. Most COPD patients, or even congestive heart failure patients, when they start to decline and their shortness of breath worsens or their orthopnea worsens, the likelihood is they're not sleeping in bed with pillows anymore. They are now sleeping in the recliner chair or at a table because they just can't breathe laying flat. That's when you know we're getting to a much greater stage of illness. Paroxysmal nocturnal dyspnea, PND, which is shortness of breath that occurs 1 to 2 hours into sleep, concurrent with redistribution of bodily fluids and subsequent rise in left atrial pressure. So the patient will awaken suddenly with difficulty breathing. They usually stand up or sit up, and then their symptoms are relieved in about 10 to 20 minutes. With dyspnea, the diagnostics you want to order at minimum depends on the patient, their history, presentation, other symptoms. But the likelihood is you'll need to order a chest x-ray, EKG. You want to evaluate for infection. So you're going to do a CBC, you're going to check for anemia, and you're going to look at their metabolic panel. Okay, palpitations or chest pain. Or, actually palpitations is more an awareness of the beating of one's heart. It may be benign or pathological. Now, in terms of palpitations, when they feel that racing of their heart in their chest or that beating, are they also experiencing any syncope? Any other symptoms? What is the frequency? How long are they experiencing these symptoms for? how often. You really want to make sure you're getting the details to kind of guide your diagnostics. You also want to make sure you're looking at your differential diagnostics because palpitations are very common in patients with paroxysmal AFib, SVT, PAT, thyroid disease, electrolyte disorders, and anemia. So your diagnostics are definitely going to include an EKG, if indicated, the Holter monitoring, which is where your heart is monitored at home. You're going to do a CBC, a thyroid, and a metabolic profile. Okay, again, diagnostic reasoning, in terms of palpitations and when you should rule out what. This is a great algorithm, another great tool if you do work any kind of cardiac floors or cardiac practice. This is a great tool to have in your notes. Okay, more chief complaints: leg aches and peripheral edema. So in terms of leg aches, we're always looking at peripheral vascular disease. In terms of the veins, incompetent valves, varicose veins. And in terms of the arteries with atherosclerosis, you're looking at a lot of pallor. And then you're going to ask both of, how's it going when they're walking? When are they getting the pain? Is it when they're getting intermittent cramping, or is it constant? Differential diagnosis include thrombosis, phlebitis, polycythemia, anemia, Raynaud's, and Berger's disease. We definitely want to do some primary prevention with these patients that are complaining of leg aches, peripheral edema, in terms of talking about and educating on smoking cessation, getting our high blood pressure under control, as well as making sure our nutrition is on point, and of course, diabetic management. Peripheral edema is obviously edema in the lower extremities. Cardiac conditions like heart failure, chronic venous insufficiency, or thrombophlebitis, as well as renal and hepatic disease, trauma, tumors, or inflammation can all be causes of peripheral edema. It usually occurs equally in men and women. And in order to identify the cause, you need to also look at the other symptoms. So we need more information with peripheral edema. We need an EKG. We need a chest x-ray. We need cardiac enzymes, a metabolic profile, CBC, urine, thyroid, and of course, Doppler studies, especially when we start to have any kind of concern about our circulation and we start to develop any kind of wounds. Okay, next we're going into hypertension. So big thing you want to make sure you're understanding about hypertension, COPD. They all have evidence-based practice gold standards that are already listed very clearly with guides for you to know and follow. This is not guesswork. There is some trial and error that comes with trying patients on certain drugs as listed by the guidelines. But for the most part, you follow the guidelines. It's pretty self-explanatory. The Joint National Committee, the GNC7 is the report you always are going to want to refer back to, or the American Heart Association Task Force. They're the ones who come up with the current standards of managing hypertension. So please make sure you keep up to date with that. So hypertension, okay, so causes. All right, 1 in 3 Americans have hypertension or high blood pressure. Obviously, it's a public health concern. A lot of the times hypertension is associated with obesity, obviously, and the obesity rates are going up, which in turn means the hypertension rates are going up. So it definitely is more prevalent in African-American women than African-American men. And just keep in mind, again, back to those US Task Force Healthy People 2020 goals. One of their goals is to improve cardiovascular health, quality of life through prevention, detection, and treatment of risk factors, early identification and treatment of heart attacks and strokes, and the prevention of recurrent cardiovascular events. So in this particular goal, getting high blood pressure under control is obviously a big concern. So obviously your high blood pressure risk rises with age. And of course, your morbidity, hypertension can cause death and is worsened. The morbidity is worsened if the patient is overweight or obese. We know that a BMI of greater than 30 obviously puts the patient at a high risk for high blood pressure, cardiovascular disease, while doubling the lifetime risk of heart failure. That's a big, big thing. So one of the biggest things you need to keep in mind with your patients who are diagnosed with hypertension is you need to get them on a good nutritional diet plan and exercise plan. All right. So hopefully in your practice, you can refer them to a registered dietitian that can help them cut their calories and get them on the right weight loss goals, as well as, somebody who you can refer them to help guide them in their exercise routine. Okay. Two types of hypertension: primary or essential hypertension, which is 95% of patients with no single identifiable cause. And then we have our secondary hypertension, which is 5% of patients due to a specific and potentially reversible cause, like OSA, cardiac, renal, endocrine, vasoconstricting, and other medications, NSAID, smoking, and then licorice. So remember, white coat pseudohypertension is just a transient rise in blood pressure likely to due to anxiety. White coat syndrome is very common. Patients who just get nervous around doctors have a tendency to just get a randomly high blood pressure while they're in their doctor's office. And then when they're back to regular life, their blood pressure is normal. So that needs to be followed up with just to make sure that is what it is, by making sure the patient records intermittent blood pressure readings over several weeks. Diastolic hypertension is with a normal systolic, and then you want to consider renovascular disease if they are having diastolic hypertension. And then masked hypertension presents during daily life and yet is absent in clinical assessment, which is kind of weird, but that does happen. Okay, evidence of target organ damage or TOD due to high blood pressure. So things you're going to see, this is actually very important. They definitely talk about this on your boards. So just keep these little clinical pearls in mind of what you might see because of target organ damage due to high blood pressure. So papilledema, hemorrhages, or hypertension in retinopathy or exudates on a fundoscopic exam. So remember, we talked about that in diabetic retinopathy, that you may see these things. Change in mental status or neurological deficits, as in a TIA or CVA, as well as increased risk of dementia. You have an ECG consistent with myocardial ischemia or infarction, LVH, and coronary artery disease resulting in angina or acute myocardial infarction. Sometimes the chest X-ray film will show hypertrophy or heart failure or an aortic dissection. And then S4 can occur in hypertension. That's a big one. Please make sure you know that. S4 is a cardiac arrhythmia that occurs because of hypertension. So if there is a question about the cause of an S4 cardiac arrhythmia, just remember hypertension. It's caused by ventricular stiffness and hypertrophy. So if you are getting an S4 in your patient, you want to make sure you include auscultation at each follow-up visit, just to make sure that it's not becoming more, you listen for anything new or anything that's indicating a worsening change. In chronic renal insufficiency or renal dysfunction, you may be evidenced by hematuria, proteinuria, and elevated serum creatinine. So you want to make sure you're sending urine at regular intervals for testing. Okay, so we have malignant hypertension or hypertensive urgency or emergency. Okay, that's when your blood pressure is over 180 over 110, and there's evidence of acute target organ disease. So elevated blood pressure alone without evidence of TOD does not constitute an emergency and is classified as a hypertensive urgency. Whether it's hypertensive urgency or emergency, in both instances, the goal is to get that blood pressure down as soon as you can. Hypertensive urgencies may be treated with oral agents over a period of 24 to 48 hours to achieve stabilization. You obviously, in a hypertensive emergency, want to refer the patient to the emergency room because they're going to likely need IV medications to get their blood pressure where it needs to be to prevent it from going into a hypertensive emergency where you do end up with target organ damage. Okay, so remember, like I said before, using guidelines to guide your clinical practice and your prescriptions for your hypertension diagnoses, you definitely want to be following your guidelines. So ACC AHA 2017, it's the JNC guidelines. That's the newest version, is number 8. That's where we're at right now. Depending on which boards you take, there are 2 different set of nursing NP boards that you can take. You want to make sure you know which boards, which board you decide to take follows which particular guideline in terms of the hypertension. But most of them, most practices follow the JNC guidelines. Okay, so here's a quick review on medications and how we're prescribing antihypertensives.
Hypertension is most commonly associated with an increase in vascular resistance caused by narrower or stiffer blood vessels. But other mechanisms, including increased cardiac output, large blood volume, or excess venous return, are possible. These factors are the targets of antihypertensive agents, which can be grouped into several categories. Diuretics, which promote sodium and water excretion by the kidneys and thereby decrease blood volume. Medications that inhibit the sympathetic nervous system or the renin-angiotensin system. And vasodilators, which dilate blood vessels and thereby decrease vascular resistance. Of the three classes of diuretics used for treating hypertension, thiazides are the most commonly prescribed. Thiazides act on the distal tubule of nephrons, which reabsorbs only a small portion of the sodium load, so their diuretic effect is less powerful than that of loop diuretics, which act on the thick ascending limb of the loop of Henle. However, thiazides also have a vasodilation effect by an unknown mechanism. The two classes produce similar side effects, but the side effects are more severe with loop diuretics. Potassium sparing diuretics act mainly in the collecting duct and have only a mild diuretic effect, but they can compensate for the potassium loss induced by other diuretics and are therefore commonly used in conjunction with thiazide or loop diuretics. Sympathetic inhibitors, or sympatholytics, act on adrenergic receptors to block sympathetic activity. There are beta blockers, alpha blockers, mixed alpha and beta blockers, and central sympatholytics. Beta blockers are typical first-line treatment for hypertension. They reduce heart rate and cardiac contractility and thus decrease cardiac output. Alpha 1 blockers are effective in reducing sympathetic vasoconstriction, but their action can lead to an excessive baroreceptor mediated reflux that increases heart rate and produces tachycardia. Non-selective adrenergic antagonists block both alpha and beta receptors. By inhibiting beta receptors in the heart, they are able to lower blood pressure without inducing reflex tachycardia. Central sympatholytics stimulate alpha 2 receptors in the brainstem to reduce sympathetic tone. They reduce heart rate, contractility, and vasoconstriction, but may also cause sedation. Renin-angiotensin system blockers include ACE inhibitors and angiotensin receptor blockers. ACE inhibitors are commonly used as first-line treatment for hypertension. They block the conversion of angiotensin 1 to angiotensin 2, which in turn leads to a reduction in aldosterone. Their action reduces systemic vasoconstriction and increases sodium and water excretion by the kidneys. Angiotensin receptor blockers inhibit the effects of angiotensin 2. Their indications are similar to those of ACE inhibitors. Vasodilators include calcium channel blockers, direct arterial vasodilators, and nitrodilators. Calcium channel blockers inhibit L-type calcium channels that are responsible for smooth muscle contraction, cardiac myocyte contraction, and action potential generation in cardiac nodal tissue. The dihydropyridine class acts on peripheral blood vessels. They are powerful vasodilators, but their action can lead to reflex tachycardia and increased cardiac contractility. Non-dihydropyridine agents, on the other hand, primarily act to decrease heart rate, contractility, and cardiac conduction speed, and are less effective on peripheral vessels. By having cardiac depressant effect, they can reduce blood pressure without producing reflex cardiac stimulation. However, they should not be used for patients with systolic heart failure. The mechanisms of direct arterial vasodilators are not entirely clear. They can cause reflex tachycardia and are only used for short-term treatment of refractory hypertension. Nitrodilators act by releasing nitric oxide, a powerful vasodilator. They are administered intravenously to manage hypertensive crises and to control blood pressure during surgery.
Great. I hope this review was helpful. It's very short. When it comes to complex concepts like this, when we're dealing with different meds and how it applies to the pathophysiology. I find videos that demonstrate the understanding of them much more effective when they're shorter because you start to lose attention after about 6 or 7 minutes. It's too much. All right, so hypertension diagnosis is typically made after several routine outpatient visits with the patient complaining of no symptoms. So we want to see a systolic of greater than 130 and a diastolic between 80 and 90. Okay, so we want average of 2 readings at least 2 minutes apart. Okay, again, another great algorithm in terms of a normal blood pressure, elevated 120 to 129. We're going to start with class 1, no drugs, and just reassess in 3 to 6 months. Now we're getting to stage 1 hypertension, right? We're going to start with non-pharmacological class. We could, based on these clinical assessments, or if we decided we wanted to start on the class 1, we'd reassess in 1 month, and then we would blood pressure was met. No, then we want to start optimizing adherence to therapy and consider intensification of therapy. So here is definitely what you want to make sure you know your parameters: normal 120 over 80, elevated 120 to 129 over 80. Stage 1 would be anything 130 systolic with diastolic anywhere between 80 to 89, and stage 2 hypertension is anything greater over 140 over 90. Okay, first visit, diagnostic hypertension, the exam. So these are all the different things in your exam that you need to make sure to check in terms of diagnosing hypertension. Okay, exam, you want to look at their height, weight, obesity. We do need to know their BMI for sure. Waist measurement, fundoscopy, carotid arteries, neck veins, check their thyroid, check their heart. S1, make sure we talked about S3 and S4 heart sounds. If we hear that S4, we know we're worrying about hypertension. Do they have any fluid in their lungs? Do they have any masses or abnormal aortic pulsations? How are their kidneys? Are they enlarged? Do they have an absence of peripheral arterial pulsations? Do they have any bruits or edema in their extremities? Definitely want to inquire about your lifestyle. Are they smokers? Do they exercise? Do they eat a lot of fried foods, fast foods? Any past medical history of their family history of anybody with strokes or CVAs, or history of high blood pressure or diabetes? What is their social situation? What are they doing at home every night? Are they eating frozen dinners that are high in sodium? Are they drinking? How much are they drinking? And, remember, most people don't always tell you the truth about how much they're drinking. There's always a rule of thumb that if they tell you they're drinking 2 glasses of wine, that probably means they're drinking 4 glasses of wine. Okay, so just keep that in mind. Medications, what are they taking? Are they taking anything over the counter, any diet pills, any energy drinks? These things can cause cardiac arrhythmias as well as elevated blood pressure. So you need to be inquiring about these things. How about salt? Do we eat a lot of salt, or frozen foods or canned foods? Okay, so diagnostics at your first visit, you want to definitely be getting a UA, BUN, creatinine to check the kidney function, CBC for anemia. We want to know our potassium for baseline status and their kidney function. Lipids are usually increased with anybody who has high blood pressure. It's to be expected. EKG, you want to look for target organ damage, CAD, arrhythmia. You want to look at their BNP to see if any evidence of heart failure. Okay, how do I initiate antihypertensives? Okay, great question. So 1 in 5 patients need medication. The use of lifestyle modification should be part of every patient's regimen to prevent or treat an elevated blood pressure. The primary care physician should work with the patient on lifestyle modification plan and medications as needed to lower the blood pressure as much as tolerated without symptoms. We don't want them getting dizzy or lightheaded with their blood pressure medications. We want to make sure we're being conscientious of choosing our medications specifically based around patients' comorbidities, their ethnicity, their history of diabetes, heart disease, and any other issues they have had in the past. So remember, if your blood pressure is 129 to 80, over 80, you don't require medications, okay? So once we start hitting 130 and 80 and above, that's when we start considering medication. In terms of lifestyle changes, obviously we want the patient to adopt a healthy lifestyle choices and have their blood pressure evaluated every 3 to 6 months. This is likely where you're going to educate your patient to really try to be an active participant in their monitoring of their day-to-day blood pressure, and encourage them to buy a automatic blood pressure cuff from CVS. Omron tends to be the best brand, OMRON. And you want to educate your patient on how to use it, to check it pretty consistently at the same time every day after 5 minutes of resting, and just have them keep a log and bring it to you the next time they come in, just so you can get an idea of what their normal range is. You also want to educate the patient on what the abnormal range is and when they would need to call for emergency help.
It's 5 o'clock.
Okay, so in terms of lifestyle modifications, and this is for all of our diagnoses that we're discussing today, not just hypertension, but in order to work with these patients, whether it's cardiac, hypertension, high cholesterol, heart failure, these are the things we want to talk about. Weight loss. Weight loss is very, very important. You want to talk about adopting dietary approaches to stop hypertension, aka the DASH diet. We want to talk about restricting sodium. So obviously cutting out frozen foods or canned foods is very important. We want to increase our physical activity, even if that's just walking 30 minutes a day. That's better than them not doing it. And it helps with circulation. It helps with cellular regeneration. It helps with everything. It's part of healing. So definitely encourage them to start their activity. Enhanced dietary potassium. We want to make sure they either drink very limited amounts of alcohol or they just don't drink at all. And obviously, you want to encourage them to stop smoking at every visit. Okay, so treatment, hypertension treatment. Do I start antihypertensives? So if we're at stage 1 hypertension, we want to calculate our 10-year CVHD and stroke risk. If it's less than 10%, now remember, you're following the JNC guidelines, so you'll see that that calculation when you're looking at your algorithms from their guidelines. So if the risk is less than 10%, you may institute lifestyle changes and reassess the blood pressure in 3 to 6 months. In general, there is more of a push to use medications if the patient is hypertensive. So again, this is, based on your clinical judgment, even though they may not calculate at a very high risk or a risk more than 10%, based on the patient and the likelihood of them putting into place lifestyle changes or making any changes at all to help their blood pressure come down, you have to decide if putting them on medication sooner than later might be in their best interest. So if the risk is greater than 10%, you want to institute lifestyle changes as well as start the antihypertensive medication with monthly follow-up visits until their blood pressure is controlled. A lot of education here with these patients, okay? Not only about lifestyle changes, encouraging them to make these changes, but also educating them on what the appropriate blood pressure parameters are and what signs and symptoms they need to report that would indicate their blood pressure is becoming out of control. Stage 2 hypertension, obviously, as well in stage 2, you want to instill the lifestyle changes, as well as you want to incorporate antihypertensive medications from 2 pharmacological classes, not 1, but 2, with a monthly follow-up visit, again, until the control of the blood pressure is achieved. So selecting treatment options. So we have quite a few guideline recommendations. Again, JNC guidelines. So they recommend picking agents from 4 different drug classes. We have thiazide diuretics, calcium channel blockers, ACE, angiotensin converting enzyme inhibitors, or ARBs, angiotensin receptor blockers. And those are the ones that we're basically choosing from. So you want to make sure that you read table 35.1 for a detailed medication selection. Many adults, most people require more than one to get their blood pressure under control. The most important thing is just keep in mind, we usually start with a thiazide diuretic for most people. It's the best first line option. It's mild and most people respond well to it. But again, most people require more than one agent, but you start slowly and you see how they do. So improved adherence may be achieved with once daily drug dosing rather than multiple dosing and with combination therapy. That's true. A lot of these patients you'll find have never even taken medications for anything. And so all of a sudden you're going to start throwing, a couple of pills at them every day. Like suddenly that's their new norm. That doesn't always fly with a lot of patients. So you really want to be gentle and really try to go with what they're willing to comply to, because there's no point if they're not going to actually, follow through and take the medication. Okay, so examples of medication choices in hypertension. Make sure you review and use the JNCC guidelines. Really important. But keeping these things in mind. You want to make selections on your medications considering ethnicity, comorbidities, side effect profile of medications. So here are some things you need to take into consideration when you're prescribing. Number one, are they African American? Okay. ACE inhibitors are less effective in African Americans. So you want to likely not use an ACE inhibitor in African Americans. You want to choose a CCB or a thiazide in an African American. So these other things you need to keep in mind: if the patient has diabetes, CKD, heart failure, CAD, post-MI, or CVA, this is when you would use for these particular patients. Definitely keep in mind also thiazides can benefit in osteoporosis. You do not want to use an ACE inhibitor or ARB in chronic kidney disorder patients, or CKD patients, if there's renal failure present. And these are the other rules of thumb in terms of when to use it, when to not. Okay, again, this is your chart, when to use these particular commonly prescribed drugs in these particular comorbidities and when to not use them. So we have our antihypertensives, calcium channel blockers, ACE and ARBs. I'm not going to read these to you. I know you guys are going over these in general in pharm. I will just quickly go through these slides. So we have these different classes of antihypertensives. This calcium channel blockers, remember, can cause leg edema. ACE inhibitors, ARBs. You want to make sure you're monitoring for hyperkalemia. If they're allergic to one class, consider that they're allergic to both. Okay, just keep that in mind. Alpha adrenergic blockers, they also have a beneficial effect on hyperlipidemia. So if you have a patient with both high blood pressure and hyperlipidemia, this is the drug of choice. Beta blockers, no longer the first line. Remember, it's thiazides. You don't want to use this in asthma or peripheral vascular disease. Be very careful in diabetes. Okay. So again, thiazides are first line in most instances. See the guideline. Watch your labs. Okay, so if the goal of the blood pressure is not attained, like meaning the blood pressure is still elevated and you're not getting the number you want to get, you need to up titrate the dose of the current pharmacological agent. So that's what you may need to do. You need to increase the dose of what they're currently on. Alternatively, a second pharmacological agent from another class may be added at a low starting dose. If the blood pressure goals are not obtained with the two blood pressure agents, a third agent may be added, although the clinician must be aware of the risk of polypharmacy. If the patient cannot respond to the triple therapy regimen, they may require referral to a cardiologist or a hypertension specialist. The likelihood is, if they're going to require more than 2 medications to keep their blood pressure under control, yes, they're going to need a referral to a cardiologist. The likelihood is for most of these patients that end up with hypertension and multiple comorbidities, you want specialists involved. A lot of the times, especially recently with COVID, it takes a long time to get appointments with these particular specialists. So the sooner you make that referral, the better, just to get that ball rolling, especially, God forbid, the patient starts to worsen and you really do need that consultation. Okay, so follow-up and referrals. So lifestyle modification, you want to have the patient follow up every 3 to 6 months to determine if their medication is effective and they're adhering to the regimen of recommended behavioral and lifestyle changes. Okay, again, as soon as you make a change in people's medications, you need to make sure there's a follow-up appointment scheduled, because you need to make sure the treatment you're initiating is working, whether it's for blood pressure or for any other issue. Okay, remember, patients forget to follow up and they start to ignore stuff. So you need to be their advocate and really reinforce that they're there for a reason and you're there to help them treat it or hopefully fix it. So definitely with high blood pressure, you want to make sure you're monitoring the serum potassium and creatinine levels, which need to be monitored several times per year, or more if indicated, just to make sure our kidneys don't go into any kind of kidney failure. We want to check for refractory hypertension, secondary hypertension, and again, refer to cardiologist or hypertension specialist if necessary. Remember to educate your patient on symptoms to make sure they are following up with, if they do occur: syncope, chest pain, dizziness, blurred vision, sudden fatigue. Have their caregivers be aware, and the patients as well, of when they need to follow up for any kind of emergency situation. So other things you need to consider in terms of what can cause high blood pressure. A lot of over-the-counter medications can cause elevated blood pressure. Cold and allergy preparations should be cautioned against. You have to be very careful with NSAIDs because they can also raise the blood pressure and have potential cardiac side effects. Age-related concerns, we're always worried about postural hypotension and dehydration. So remember, when a patient becomes dehydrated, their blood pressure tends to drop, which can lead to a syncopal episode. Remember, always reinforce and encourage lifestyle changes and give them any resources available that would actually help facilitate those lifestyle changes. So the recommendations for blood pressure goals and blood pressure management change pretty frequently. So you want to make sure you're checking frequently onto the JNCC website to make sure that you're up to par with the current guidelines. Okay, lipid management or cholesterol management. Here we go. What is dyslipidemia? Dyslipidemia is elevated concentrations of any or all plasma lipids. The major risk factors for dyslipidemia or high cholesterol is coronary vascular disease or acute coronary syndrome. So marker for CVD. We want to make sure, again, we're following the guidelines. This is evidence-based practice that gives us the guidelines as practitioners as to when to start statin therapy, as well as the risk factors to make sure you're assessing for. So you want to recommend statin therapy in individuals who do not currently have CVD, but who have a 7.5% greater risk for stroke or heart attack. Okay, so primary causes of high cholesterol or dyslipidemia: genetic, obviously, if a family history of that; behavioral factors like a dietary consumption of fats and a lack of physical activity, as well as metabolic syndrome. Those are your primary causes. So obviously the secondary causes would be anything that would lead to that, which would be obesity, diabetes mellitus, hypothyroidism, nephrotic syndrome, end-stage renal disease, excessive alcohol consumption, hepatic disorders, steroids, beta blockers, HIV, protease inhibitors, growth hormone. Any of these are your secondary causes of dyslipidemia. Again, make sure you know your lab values for your lipids. It's super important. You want to know the different ones. So we have our HDL, our triglycerides, and our total cholesterol. Okay. Again, this is all part of the National Heart and Lung and Blood Institute guidelines. So that's where we're getting these normal and abnormal guidelines for cholesterol. Okay. Therapy should be initiated when a patient's 10-year risk for a first atherosclerotic ACVSD event is 7.5%. So they have a calculator to assess this risk. So you can look that up right on the cardiology ASCVD website. Okay, physical assessments. Physical assessment findings. There's not really specific findings, but some of them may have a carotid bruit, corneal arcus, exanthomas, vascular disease. Here's your exanthomas, and underlying endocrine disease. Okay, who to treat? The latest ACC/AHA guidelines say there's no evidence to support treatment to a specific LDL target. 4 groups identified to target primary and secondary prevention and concentrate efforts aimed at reducing cardiovascular events. So these are your 4 patients that are really at the high risk that you want to consider treating. So patients with a SCVD, patients with LDL levels greater than 190, patients with diabetes mellitus from 40 to 75 years old with an LDL of 70 to 189. And then, of course, you have your patients with no evidence of CVD or DM, but have levels of LDL less than 70 to 189 and a 10-year risk of greater than 7.5% based on the risk calculator. So testing to assess these higher risk groups of dyslipidemia patients is critical, as it is recommended that the first 2 groups use high intensity statins and the last 2 groups use moderate intensity statins. Should I start a statin on my patient? So this sounds like a lot of things to be assessing for looking at your patient and just deciding on one drug, much less all 10 or 15 others of the ones they're going to need, right? Because if your patient's on a statin, the likelihood is they're going to be on every other medication as well. But that That's okay. We're just going to start with the statin and we're going to focus on that. And these are the things you're really looking at. And keep in mind, these factors that you're looking on for a statin are also for all of your other cardiac meds too. You really want to be paying attention to these particular questions. So, does the patient have a history of any of the following: ACS, MI, stable or unstable angina, coronary or arterial revascularization, stroke, TIA, PAD? Does the patient have an LDL level of greater than or equal to 190? Is the patient 40 to 75 years old with diabetes mellitus? Is the patient 40 to 75 with a 10-year cardiovascular risk of greater than or equal to 7.5%? So again, if any of these are yes, then the patient is a potential candidate for a statin. The likelihood is, if you're even questioning it, they're going to be a yes to one of these 4 questions. Okay, so primary goals of prescribing in dyslipidemia is to lower the elevated LDL, lower the elevated TG, and raise suboptimal levels of HDL to prevent cardiovascular disease. And here on this right side are the standards in terms of where you want those numbers. Okay, in terms of changing your lifestyle for dyslipidemia, obviously we want to change our diet, lower our cholesterol by limiting it to less than 200 milligrams a day. We want to exercise, which decreases insulin resistance and increases our HDL, which is our good cholesterol, as well as lowers our lipids. Now, remember, this is true for hypertension and hyperlipidemia, as well as cardiac disease. Any optimal regimen for hyperlipidemia should have diet and exercise as well as pharmacological therapy as indicated. Okay, so remember, no matter what you're treating, even if you're prescribing a drug, you want to also incorporate lifestyle changes and dietary changes and exercise into this patient's lifestyle. Okay, lifestyle changes, diet. So we're going to talk about a diet that is less than 7% of saturated fat. We want to have, again, the cholesterol less than 200 milligrams a day. We want to increase our fiber intake and our plant sources of plant nutrition, so veggies. We want to definitely, obviously, look at our weight and get that down and increase our physical activity. The biggest way to decrease weight is to decrease calories. Decrease calories, increase physical activity. You want to encourage a lean and green type diet. Lean meaning lean meats, lean like fish, chicken, and green meaning just vegetables, green vegetables specifically. Okay, pharmacological treatment. Usually the statins are the preferred class of drugs because statins reduce LDL, increase HDL, and reduce triglycerides. You could also prescribe niacin, which increases HDL. Zetia is also a lipid lowering agent, which reduces LDL. And you have Questran, which is a bile sequestrant, which lowers LDL. Okay, so statins, we have high, moderate, and low intensity. And this chart just goes into how these particular 3 different classifications of statins affect the lipids and what their reactions could possibly be. It also gives you the brand names as well as the dosaging, which is really important because most of the time you don't see their brand names, but sometimes they're referred to as that. So it's really important that you familiarize yourself with simvastatin is Zocor versus atorvastatin is Lipitor. Okay, so patients with ASCVD that are less than 75, you want to start with a high intensity statin to reduce their LDLs by 50%. Patients that are greater than 75, you want to use moderate intensity statin for patients with DM. And you want to reduce the LDL levels by 30 to 50%. Patients 40 to 75 years old without CVD or diabetes, but have a CV risk greater than 7.5% and an LDL level of 70 to 189 should be on a moderate intensity therapy. Okay, so these are our other possible lipid lowering agents. People sometimes take red rice yeast as a natural statin and omega-3s, but there's no evidence-based practice to support their use and their effectiveness. So be careful with that. Okay. So when it comes to prescribing the statins, you definitely want to make sure you're getting a baseline liver function test, and you want to educate the patient that it is a hepatotoxic drug, and alcohol and muscle weakness can be symptoms that They might be becoming septic, not septic, their drug might be too much in their system and causing these side effects. So we have to be very careful, a high buildup of the statin in their system. Okay, so again, follow-up is super important. Make sure you're having the patient schedule follow-up, give them a date. Like, I want to see you in a week, I want to see you in 2 weeks. Figure it out based on the patient, but make sure that they're open to their follow-up. You want to watch for side effects of statins, reduce the dose, change the medication if necessary, continually reassess about the lifestyle changes, repeat your lipid profiles just to make sure the numbers are coming down. You want to obviously consult with a cardiology and nutritionist if things are not changing and getting better. Okay, metabolic syndrome. So metabolic syndrome is, again, is another umbrella term to cover a multitude of diagnoses. So basically, it's a cluster of coronary CVD and diabetes risk factors related to insulin resistance. 3 conditions establish the diagnosis of metabolic syndrome. And of course, and you have metabolic syndrome, you want to obviously encourage weight loss and lifestyle changes. So things that would incorporate under metabolic syndrome include abdominal obesity, high triglycerides, low HDL, high blood pressure, and high fasting glucose. So abdominal obesity meaning obesity, high triglycerides meaning high cholesterol, high blood pressure meaning hypertension, and high fasting glucose meaning hyperglycemia. These are all conditions established under metabolic syndrome. If they have one of the 3 of these, they already have the syndrome. So here is a quick video just to, again, go into a very basic animation of the coronary artery disease and what it looks like just from a basic pathophysiology standpoint in an animated view.
Coronary artery disease, or atherosclerosis, is caused by plaque buildup along the inner walls of the coronary arteries, the major blood vessels that supply the heart with blood, oxygen, and nutrients. Plaque consists of fatty materials in the blood that can decrease blood flow to the heart, often resulting in a heart attack. Risk factors include family history, high cholesterol, high blood pressure, and lifestyle choices like smoking, alcohol consumption, and lack of exercise. You can reduce your risk by pursuing a healthy lifestyle or by taking medications.
Okay, quick animation. All right, coronary artery disease, or CAD, or atherosclerotic coronary artery disease, or coronary heart disease. Okay, why do we have that all listed out? Because as times change, even from when I was working on my master's and my undergrad, these classifications of CAD has changed frequently. So it's the same thing. We're talking about the same disease process here, but it's just their classification. It's the way they term it has changed a little bit. So coronary artery disease is what we're going to go with today, CAD. So the non-modifiable risk factors, obviously, males are higher risk. Anybody with an increasing age, family history of CAD, or if you're African American, these are all higher risk factors that will make you more susceptible to getting this particular disease. Modifiable risk factors, like for any disease, include hypertension, smoking, sedentary lifestyle, hyperlipidemia, and women going through menopause without estrogen replacement, as well, of course, if they smoke. Contributing factors that everybody has, well, not everybody has, that some patients have that can be modifiable or not, include obesity, stress, and diabetes mellitus. Okay, so the value of an FNP in these particular diagnoses. So CAD, metabolic syndrome, hypertension, DM, and obesity, how can we be of value in these particular diagnoses? I mean, I think we're value in all diagnoses, but in these particular section, we can definitely strongly intervene with these patients because a lot of this requires lifestyle management and changes. And sometimes that takes more time and effort and guidance than the average practitioner is willing to provide. But as a nurse practitioner, that's where we would try to slow things down and fine tune that care plan for the patient because we know how significant that would be in helping relieve these diagnoses or, hopefully minimize them, if not cure them. Through good report and patient education, helping patients maintain weight, exercise, healthy eating, stress management, health promotion activities, the FNP can help patients stay healthy and prevent and or lessen progression to worsening disease or sequelae. Don't minimize the value of solid patient education and coaching on lifestyle modifications and health promotion. So true, guys. One of the biggest things I'm going to tell you as your role as an FNP is just being that nurse navigator to give them access and make them aware of the resources that are out there to help guide them to make the best lifestyle choices for them. Whether it's referring them to a home delivery service like HelloFresh to make sure they're getting good quality meals delivered to their house, or whether it's facilitating the patient and giving them information as to their local gym and where they could actually get a good trainer to work out with. These are things that in your role as an FNP you can really be of value. Okay, so cardiac and diet. So in terms of patient education, this can be confusing. So you want to work on small goals every time the patient comes in. Most importantly, especially in hypertension and cardiac diets, you want to start with educating the patient on the DASH diet and the importance of low sodium, especially in CHF and hypertension. We want to just definitely encourage a diet that's high in vegetables, fruits, nuts, whole grains, lean vegetables, or animal protein and fish. We want to minimize the intake of trans fats, red meats, processed red meats, refined carbs, and sweetened beverages, as per the AHA guidelines for the prevention of cardiac disease. So again, these things that we're educating our patients on are really basic guidelines from AHA, and you need to make sure you're documenting that you are educating the patient on these, because that is part of your role as an NP, is to provide this education. So again, you want to talk about what you educated it on during that particular visit, as well as the patient's reaction or comprehension of that education and what they're what they verbalize in terms of their plan for follow through. You want to talk about a strict low fat diet, because obviously that can cause weight gain. You want to talk about even a Mediterranean diet, because again, that's high in fish and lean green foods. Again, plant-based diets. We just wanted to really focus on making sure all of their meals include a half a plate of vegetables, whether it's a salad, green veggies, whatever they want, but just make sure they're really getting their vegetables. We want to talk about low sodium and, of course, portion control and exercise. The American Diabetes Association and I think the American Cardiac Association, they both recognize Weight Watchers as a very good diet plan for these particular patients. So guiding your patient to just use Weight Watchers is definitely a healthy option for them, as well as it's pretty cheap in the scheme of paying for diets. Patients should get clearance with cardiology and tailor to their needs and limitations whenever. Okay, so if we want to start our patient on a really true education program, exercise program, we do need to get cardiac rehab involved and just get clearance with cardiology to make sure that they can actually sustain the exercise guidelines we're going to put in place for them. So, the goal is to move more, sit less. The goal is usually for the average patient who gets clearance to do 150 minutes of aerobic exercise per week. Spread out. You can do it in 75 minutes of more intense exercise or a combination, however you want to do it. Okay, CAD and the progression of the disease. On average, by the time the patient is symptomatic, 75% of the artery is narrowed. So before these patients even have the symptoms, like 75% of their artery is already occluded. So that's a big problem. Eventually, they'll develop exertional angina, and middle-aged men and older men and postmenopausal women are most prone to developing angina. Associated symptoms, like any other chest pain, could include radiation of the discomfort to the left arm, the jaw, nausea, shortness of breath, lightheadedness, and syncopal episodes. So in terms of diagnostic tests with coronary artery disease, you want to obviously perform an EKG, exercise EKG or a stress test if the patient is symptomatic. We want to consider nuclear scanning. This again will be referred to and consulted with a cardiologist before you decide to do any of this. So these are all the different options. But again, when we get to this point, the likelihood is this will be ordered by the cardiologist. Okay, so key clinical findings of CHD or angina pectoris. So
Some patients with CHD may experience nausea, vomiting, shortness of breath or dyspnea, epigastric pain, diaphoresis or sweating, and dizziness. Women commonly present with classic radiating chest pain. Okay. So when it comes to managing CAD, we want to establish our diagnosis, obviously, control the symptoms, prevent disease progression that may lead to an MRI or sudden death. We want to do a risk factor modification. We want to start fibrinolytic agents. We want to consider a balloon angioplasty or a stent placement or a coronary artery bypass. But again, once we're at this point, we start controlling our symptoms and working on that. That's when we're getting our consultation in place with our cardiologist to make sure we're making the best decisions here. So the primary care provider often works with cardiology and maintains post-discharge instruction, which works with the patient on risk factor modification. So we want to make sure we're very aggressive at making sure these lipids are getting lowered. We want to make sure these patients who are diabetics have strict glycemic control. We want to be aggressive with our antihypertensive therapy. We want to make sure we're educating and enforcing and encouraging smoking cessation as much as possible. And of course, modifying our lifestyle behavior changes. So remember, the importance of this is to prevent the patient from having any worsening issues like an MI. We don't want the patient to have an MI. So getting these things under control immediately is priority. Sometimes these patients will also be prescribed supplements such as coenzyme Q10, which helps reduce the side effects. That's up to the cardiologist. Okay, acute coronary syndrome. Let's look at that. Again, another umbrella term to just talk about any disorders that arise from coronary artery occlusion. So an MI would fall under this umbrella. Here in this particular quick video, we're going to talk about the two different kind of heart attacks, a STEMI versus an NSTEMI. Okay, super important to be able to differentiate, and I want you to make sure to pay attention to what the EKG will manifest with these particular types of heart attacks.
Acute coronary syndrome, ACS, is a group of conditions that occur when blood supply to an area of the heart muscle, the myocardium, is suddenly reduced or blocked. Reduced blood supply is termed ischemia. A prolonged ischemia can lead to death of the heart tissue, known as heart attack or myocardial infarction. A typical symptom of ACS is central chest pain or discomfort that may spread to the back, jaw, left shoulder, or arm. The pain may also be felt in the abdomen and can be mistaken for indigestion. Other symptoms include shortness of breath, heavy sweating, nausea, palpitations, and fainting. Women and older people often have atypical symptoms. Chest pain is not reported in about 30% of cases. About 20% of patients have mild or no symptoms. Risk factors include aging, family history of heart diseases, smoking, diabetes, hypertension, high cholesterol, obesity, sedentary lifestyle, unhealthy diets, and psychosocial stress. The most common cause of ACS is the formation of a blood clot in an artery already narrowed by an atherosclerotic plaque. Plaques are deposits of lipids, fibrous tissue, and calcium that accumulate slowly over time. A plaque may become inflamed and rupture, exposing substances that promote coagulation, producing a blood clot on top of the plaque. Less common causes include coronary artery embolism, coronary spasms, and coronary artery dissection. Depending on the location and the extent of obstruction, one of the following conditions may result: unstable angina, non-ST segment elevation myocardial infarction, non-STEMI, or ST segment elevation myocardial infarction, STEMI. These conditions are differentiated based on ECG findings and cardiac marker levels. Markers are substances released into the bloodstream upon death of cardiac myocytes. Cardiac troponins are the markers of choice as they become elevated early in the disease process. The amount of troponin released is proportional to the infarct size. Most patients with infarction show elevated troponin levels within 6 hours. Troponin assay is usually done on presentation and then repeated a few hours later. Unstable angina is basically ischemia without infarction. It impairs cardiac function but has not caused cell death. ECG changes are absent or transient. Cardiac troponin levels remain normal or only slightly elevated. It should be noted, however, that this condition is clinically unstable and often precedes a myocardial infarction. Non-STEMI is infarction that is limited to the inner layer of the ventricular wall. Cardiac marker levels are elevated as a result of myocardial cell death. ECG changes may include ST segment depression or T-wave inversion, but not ST segment elevation. STEMI is infarction that extends the entire thickness of the myocardium. STEMI results from a complete and persistent occlusion of blood flow. ECG findings show a characteristic ST segment elevation. There is usually a reciprocal ST depression in the electrically opposite leads. The location of infarction can be identified based on the leads with ST elevation. Cardiac markers are elevated. All patients with suspected ACS are treated promptly with antiplatelets, usually aspirin, angina medications, usually nitroglycerin, and supplemental oxygen if required. Once diagnosis is confirmed, anticoagulants, beta blockers, ACE inhibitors, and statin are usually initiated within 24 hours unless otherwise contraindicated. For STEMI patients, emergency percutaneous coronary intervention, PCI, is the preferred procedure to restore blood flow. If PCI is not available, a fibrinolytic therapy is usually initiated at the earliest possible time. For patients with unstable angina or non-STEMI, an angiography to identify sites of blockage may be done within 24 to 48 hours if the patient is clinically stable and the case is uncomplicated. For complicated cases, angiography must be done immediately. Fibrinolytic therapies are not indicated for non-STEMI patients.
Okay, guys, I hope this was helpful. I really love how he does that visual of the troponin levels and how they are evaluated pretty quickly because they rise within 6 hours. So just make sure you know the cardiac markers that you would need to be assessing for if you were concerned about an MI or an impending MI. Okay, again, acute coronary syndromes, disorders of the myocardial ischemia. So we're talking about stable angina versus unstable angina versus variant angina versus an MI. Remember, unstable angina usually precedes an MI. Okay, stable angina, transient chest pain related to activity, lasts 3 to 15 minutes, associated with symptoms. Biggest thing with stable angina, you need to remember, it's relieved with rest and nitroglycerin, okay? That's the most important thing. Stable angina, you get a little chest pain here and there with a little exertion. You sit down, you rest, it goes away. You take a little nitro, it's gone, all right? If it doesn't go away after a few minutes, or you take that nitro and you wait 15 minutes, you take another one, you wait another 15 minutes, and it's still not going away as well as it's getting worse, that's when we want to make sure the patient is calling 911. Unstable angina, meaning it comes and goes randomly. It's more severe chest pain. It's brought on with less exertion, or it's even brought on at rest. It's prolonged, and we're not getting any relief from rest or even full relief. The nitro isn't helping. They require morphine to help relieve their breathing. Obviously, we need to get an emergent evaluation. This is hard. When you get the unstable angina, it's very hard to distinguish that from a MI. Okay. Okay, then we have a variant. It's called Prince-Metal's angina. This is chest pain at rest with ischemic EKG changes, which is due to abnormal coronary artery vasospasm. It's unrelated to activity. It can be associated with Raynaud's or migraines. It is cyclical at times, may occur during sleep. The associated symptoms may subside with exercise. And the prescriptions usually would be calcium channel blockers or long-acting nitrates. We want to definitely avoid beta blockers in this particular diagnosis. So again, here we break down the different types of forms of angina or chest pain. Okay, important to know your little STEMI versus non-STEMI, okay? STEMI is an ST elevated MI, which is full wall, versus a non-ST elevated MI, which is non-occlusive or partial wall. So remember, your STEMI is way worse than your non-STEMI. Okay, ACS risk and contributing factors. Males are greater risk than female. After menopause, the rate of female MI increases significantly. The majority of patients happens in greater than 65 years old. African Americans have a higher rate because they also have a higher rate of hypertension. Average age for the first MI for men is 65.3 years old and 71 years old in women. Most common in Western societies, and African Americans have a higher incidence because of their greater incidence of hypertension. Contributing factors: CHD, tachycardia, LVH, anemia, increased platelet aggregation, abuse of illegal substances like cocaine and amphetamines, which cause racing of the heart, which can contribute to decreased perfusion of the coronary arteries. So it's similar to chest pain in terms of the exam. You want to include inspection, palpation, and auscultation. You definitely are looking for dyspnea and diaphoresis. You want to make sure they're not sweating or they're not short of breath even at rest, doing nothing. In an MI, you're most likely to see the patient becomes very pale. Their skin becomes cool and diaphoretic. They're like cool and sweating at the same time. Sometimes you'll hear rails or crackles on auscultation. You'll hear an S3 or an S4 murmur. Most of the time, you're going to see some edema of the extremities and as well as some jugular vein distension. You want to listen for that transient third or fourth S3, S4 heart sound. It might be a transient mitral regurg murmur and or a carotid arterial bruit. Whenever you see diaphoresis and the chest is heaving from the breathing, you really want to become worried because it often indicates that the cardiac output is dropping and you may be leading into a more serious worsening status. Okay, MI symptoms. So remember, in females, we tend to see more of a GI symptom than anything else. They tend to feel nauseous, tired, and lightheaded. That tends to be more of the female symptom of a major heart attack as opposed to the man, where you're getting the typical chest pain radiating to the jaw, neck, or arm, as well as diaphoresis. Sometimes women don't even complain of chest pain. It's just that nauseous feeling. And 15% of patients in general are asymptomatic. So just keep that in mind. So you want to inquire about the chest pain and other presenting symptoms. Do your old cart, onset, location, duration, the whole thing. You want to do a review of systems, including at minimum cardiovascular, pulmonary, and GI. You want to look at their family and social history, detect any risk factors: smoking, substance abuse, and family cardiovascular history. Especially when you're trying to determine the patient's risk factors, you want to know that genetic profile. Cardiovascular exam includes auscultation over the precordium. You want to, again, be listening for S3 or S4, any new onset murmurs, carotid bruits, JVD, peripheral pulses. You want to look at peripheral edema, any low-grade fever. You want to check their respiratory status, listen for any rails, crackles. You want to look at their GI status, neurological status, and just a general overview. Any anxiety, impending doom feelings, these are all concerns when it comes to MIs. Diagnostics, like we talked about, you're checking troponin levels. We want to look at CKMB levels and myoglobin. All these would also be diagnostics you would want to look at: electrolytes, CBC, BUN, chest X-ray, 12-lead EKG for sure. Okay, so door to balloon, 90 minutes. So some places, specialty centers offer the cardiac caths, and if it's appropriate for the patient, great. But it has to be done very quickly. So that's something you have to really triage your patient for to determine if that's appropriate. Again, this is where you're going to be consulting with cardiology. So types of MI, STEMI versus non-STEMI, which we talked about. You want to make sure you can recognize what that looks like when you look at an EKG. EKG strips are hard, especially if you don't have consistent experience with that, but you should be able to recognize certain cardiac dysrhythmias, including a STEMI versus a non-STEMI. Okay, so here we go. I put them on here. These are very clear drawings, but in reality, when you actually look at an EKG rhythm strip, it's not going to probably be this clear. But this is what you're looking for. So ST segment elevation of more than 1 mm, in a continuous lead is usually indicative of an MI. So here we are. Same thing here, inverted T waves or significant Q waves over here. So be aware that not every ST elevation means an MI. It's usually due to cardiac or electrolyte conditions, making it difficult to distinguish. So this is a mnemonic for causes of ST elevation, but anytime there is that ST elevation when you're looking at an EKG, you always want to come back to the patient and really base what you're looking at around their symptoms to make sure that their symptoms are actually indicative of what's going on, and you're following your plan of care based on the severity of what's going on with them, not just what you're seeing in that moment on their EKG. Okay, so here I just wanted to do a quick review, like again, a quick video just to review what normal sinus rhythm looks like on an EKG. And then, as long as you remember what a normal sinus rhythm looks like and you're really able to fine tune and differentiate that, then it becomes a lot easier to recognize what an abnormal rhythm looks like. So I just wanted to really do a quick review of that for you guys, 3-minute video, just really quick visual.
Normal sinus rhythm is the default cardiac rhythm that represents the normal electrical activity through the heart. Electrical impulses start at the sinoatrial node, also known as the heart's pacemaker. This produces electrical impulses that are sent to the AV node and subsequently to the ventricles. If you want to learn more about the heart's electrical conduction in more detail, check out the link for this video in the description below. In normal sinus rhythm, QRS complexes are narrow and always preceded by P waves. I'll repeat this because of how important this is. P waves should always come before QRS complexes. This is what defines a sinus rhythm. If you don't see P waves, then the rhythm is not sinus. Take, for example, this strip where P waves are not seen. This is an example of a junctional rhythm where the pacemaker is not coming from the sinoatrial node. Between these two waves is the PR interval, and in normal sinus rhythm, this interval is always constant and less than 200 milliseconds. This represents the inherent delay of depolarization from the atria to the ventricles through the AV node. Intervals that are way too short can represent abnormal accessory pathways seen here, and intervals that are too long can represent AV blocks seen here. Subsequently, depolarization through the ventricles is fast, leading to narrow QRS complexes occurring at a rate between 60 to 100 beats per minute. Now, you could have rates below 60 beats per minute that are still sinus, but these are referred to as sinus bradycardia, and rates that are greater than 100 beats per minute and still sinus, which we call sinus tachycardia. And finally, the ventricles repolarize, which is represented on your rhythm strip as a T wave. This interval to repolarization should fall between 400 to 440 milliseconds after the initiation of the QRS complex. This is called the QT interval. So in summary, in normal sinus rhythm, you will see narrow QRS complexes, which occur regularly at a rate between 60 to 100 beats per minute. These are always preceded by P waves, and PR intervals that are constant, usually less than 200 milliseconds. And finally, T waves after QRS complexes, representing ventricular repolarization. If you enjoyed this video, make sure to hit the like button or leave a comment below.
All right, guys.
I try my best to read all your comments.
Was a quick little review, and I want to make sure to reiterate that YouTube is a great source for really fine-tuning little things that you may not have understood in previous classes. I would encourage you to just watch videos on particular pieces to subject matter. If you're struggling with it, watch it over and over again until you really start to grasp it, because these little concepts, like for instance, really understanding the normal sinus rhythm on an EKG, will really help you going forward, not only obviously in your studies, but in your clinical practice as well. So again, here's just your example of what the difference is between a non-STEMI and a STEMI. Okay, so here we have like your basic lead that will show you an example of a STEMI. So the ST segment elevation in leads 1 and leads V1 through 5 from the anterior wall, see the yellow highlighted, and then the reciprocal change of the ST segment depression inferior highlighted in blue. Okay. So again, T wave inversion versus ST elevation versus Q wave. Okay, so that's how you need to differentiate. When we're looking at an EKG strip, if we're seeing a T wave inversion, we're concerned about ischemia. If we're seeing ST segment elevation, we're concerned that, not only did we have ischemia, we actually have injury. Or did we have infarction? Is the damage already done? And that you would see in a significant Q wave. Okay. Okay, so 12 lead MI detection. Be methodical each time. So super important to figure out your system and be consistent about reading a 12 lead EKG every time. So first things first, you want to determine your rate and rhythm on your EKG strip. Then you want to know, is there a left bundle branch block present? Then you want to know, is this new or is this a result of an MI? Is there ST segment elevation? Because predictable patterns of damage on an EKG depend on the area of injury, tells you which surface is injured, okay? So you need to figure out where is the ST segment, is there ST segment elevation, and is there axis deviation? Because keep in mind, in cardiac disease, the wave of depolarization swings away from areas of damage or necrosis, creating electrical axis deviation, which is another means of determining an MI. And you also want to consider evaluating the patient for left ventricular hypertrophy. So this is where you would see the abnormality or changes in the EKG and which arteries would be affected. Okay, this gets into axis deviation. Okay, so differential diagnosis is the same as acute coronary syndrome. The most important thing is, you want to make sure the patient is stable with aspirin or nitro, and then you want to make sure that you do not delay in getting this patient transferred to a hospital-based emergency care setting as soon as possible, preferably, obviously, one with cardiac catheterization lab. But the goal is to reperfuse the myocardium to prevent, the dysfunction of the left ventricle by giving thrombolytics, angioplasty, a cabbage, or stents as needed. So after an MI, again, there's guidelines that these particular post-MI patients need to have put in place for them. So based on the guidelines, this patient will be placed on an aspirin indefinitely. Starting them on a beta blocker will likely reduce their mortality pretty significantly. The ACE and or the ARB, you want to decrease the LV function and reduce mortality. You want to get them on a lipid lowering agent to make sure their cholesterol stays where it should. You want to make sure, you may see that they need antiplatelet meds, an addition of a diuretic if they're retaining any fluids, an antiarrhythmic if they have any kind of arrhythmia going on. You want to make sure they don't develop any new problems like more cholesterol issues or diabetes. Did they have any surgery? If they had a cabbage, you want to make sure they get their post-op follow-up visit. Did they have a pacemaker put in? You want to make sure, or a defibrillator, make sure they're being provided with education on follow-ups, as well as the caregivers into when they need to make sure to follow up or notify 911 if anything doesn't work. You want to make sure this patient is being followed by cardiology and that they go consistently to their follow-up appointments. You want to reduce further risk factors with lifestyle and behavioral changes, continuous education on smoking cessation, diet, and exercise. You want to consider referring this patient for cardiac rehab if they're eligible. You definitely want to consider a mental health referral because a lot of these times these patients become depressed, especially after a full MI. And you want to help them apply for disability if any of them need financial support because they may not be able to work depending on their occupation or their age. So applying it to practice. So below contributes to how they view themselves in the world and may need time to adjust post-MI, cabbage, pacemaker, defibrillator, etc., and how the patient may benefit from your support as an FNP. So the likelihood is this was an acute event and they really haven't had time to process like what just happened to them, meaning they almost died. So once the patient starts to realize, oh my God, I almost just died and was very close to it, and they may have died and come back because they were resuscitated, this can really mess with people's heads and they may start to freak out a little and have some of the blues. They may not be able to sleep. The likelihood is the first 6 weeks after the MI or any kind of cardiac surgery, they won't sleep more than 2 to 3 hours at a time. That is a very consistent thing you'll hear from patients. Give them hope, tell them to just try to rest when they can, and they will get through it, and just let them know there's a light at the end of the tunnel. within 6 weeks, their body starts to regain homeostasis and things start to get better. You want to make sure your post-op pain is managed. If they have any suture lines, incision lines, make sure you're not seeing any signs of infection. Refer them to home care services if any wound care is needed or any further education or medication management is needed. Please do not hesitate to refer these patients for at-home visiting nurse service so they can get a nurse at home to educate them and just give them basic day-to-day guidance in terms of their home and lifestyle management, including daily weights, dietary stuff. Visiting nurses do a lot of that. They can get social workers in the home to help with any kind of financial or living situations if the patient needed some more help at home, especially with caregiver support, that kind of thing. So of course, we do want to consider outpatient cardiac rehab, but before they even get to that, they may need to go home after their cardiac incident and procedure and go home with visiting nurse and then transition to cardiac rehab. So just consider that. So things that could happen in addition to the MI or at the same time that sometimes are high risk for, a patient is high risk for, so they could have a ruptured septum or wall. They could have an arrhythmia that develops into arrest. They could have go into congestive heart failure. They could have a new onset murmur, cardiogenic shock, or cardiac arrest. Okay, last but not least, heart failure. We're almost done, guys. Heart failure is the final thing we're going to talk about today. Remember, it's a condition in which cardiac output is insufficient to meet the body's metabolic demands. So unlike other cardiac disease, an increase in heart failure is likely due to an increased survival from other cardiac diseases. So basically, as any heart condition that you have gets worse, the likelihood is it will eventually manifest into heart failure, meaning your heart is starting to fail. Like it can only keep up with all these heart issues you've been having for so long, and now it's starting to really decompensate. So heart failure is the most common discharge diagnosis in patients older than 65. The prognosis is that 50% of people die within 5 years of a heart failure diagnosis. So they don't have a lot of time. So they definitely need cardiology at the heart failure stage, especially in the later stages, to manage it. All right. I would not even wait till the later stages. For my patients, if they have heart failure, they're getting referred to a cardiologist immediately. We want as much support as we can get for these patients. There's no reason to wait, especially if you see that lifestyle modifications or changes are really not practical for this particular patient. You want to definitely identify the cause and precipitating factors of the heart failure. So obviously they're at risk if they have infectious disease, obesity, anemia, if they're pregnant, if they have diabetes, chronic renal insufficiency, myocarditis, valvular disorders, pulmonary emboli, sleep apnea. Alcohol abuse is a big one, substance abuse, and chemotherapeutics. All of these put patients at extremely high risk for heart failure. Progressive disease, which results from a dysfunctional ventricle. And so basically we're unable to eject an adequate amount of blood, meaning systolic dysfunction as well as diastolic dysfunction. CHF typically presents with vascular congestion in the lungs or systemic venous return to the heart. So keep in mind, the NYHA has a classification of heart failure severity as well as the ACC-AHA for staging heart failure. You just want to keep in mind and be aware that there are 4 different stages, whether it's the number 1 through 4 or ABCD, there's 4 different stages of heart failure. And so one is the classification of heart failure severity, and one is staging the criteria of heart failure. So just be aware of what symptoms puts you in what level of classification. So basically the higher the number, the worse the heart failure. So 1 is asymptomatic. They don't have any symptoms. Number 4, they have heart failure symptoms even at rest. They can't breathe and they're filled with fluid. Okay, so subjective in these patients, you're going to see dyspnea, orthopnea, a cough, chest pain, weight gain, a lot of edema in their legs, usually, sometimes in their hands. When it gets to the later stages, it's usually all the extremities as well as the abdomen as well as the eyes. And this central nervous system, one of the things you'll see from a mental status standpoint when they start to go into heart failure, obviously oxygenation becomes an issue. So one of the things that you'll start to see is a change in their mental status where they will exhibit confusion and anxiety. So keep that in mind. Don't take it personally. Just realize that they're probably going into heart failure. So the other things you're going to see: paleness, fast heart rate, weak pulse, alternating with a strong pulse. You may hear S3 murmur. Again, remember those S3, S4s for hypertension and heart failure. Okay, you're going to hear murmurs. You're going to hear rails, crackles, wheezes. They may have a cough with pink, foamy, frothy sputum, very likely. Once you get into the habit of seeing patients in heart failure, once you see 2 or 3 of them, you won't forget it. It'll become very, very easy for you to recognize it, like just upon just seeing the patient walk in the room. Okay, so in terms of diagnostics, you want to look at their BNP. Greater than 500 is highly indicative of heart failure. Obviously, you want to get a basic stuff like an EKG and echo to look at the valves, look at for any arrhythmias or MIs. We want to look at the CBCs, check our BUN, creatinine, our troponin levels. Again, if we're worried about an MI, we want to look at our LFTs to make sure we're not getting any hepatic congestion, as well as urinalysis and a chest X-ray. Now, when we're looking at our chest X-rays, what are we seeing? We are usually seeing distension of the pulmonary veins upward from the hillock, right? The biggest thing I want you to remember about a chest X-ray finding in CHF that may come up on your boards is curly B lines. You will see curly B lines usually, which is a result of distended lymphatic vessels. Those are something that are very recognizable on a chest X-ray, and they are always associated with CHF. So just keep that in mind. If you see a question about CHF and you see an answer for curly B lines, you know you're looking at CHF. So differential diagnoses when it comes to heart failure is anxiety, lung disease, like pneumonia, because remember, pneumonia, you're filled with fluid as well. COPD, you have a lot of dyspnea. So sometimes you have to look at these different things. We're looking at venous insufficiency, nephrotic syndrome, hepatic cirrhosis, superior vena cava syndrome from a tumor obstruction, pericardial effusion, MI, anemia, or cardiomyopathy. So obviously we want to identify what's going on. We want to treat the precipitating and aggravating conditions, recognize and treat underlying cardiac disease, as well as monitoring cardiac failure. Again, at this point, we've already connected with a cardiologist. We're treating with ACE inhibitors, which is the cornerstone of HF therapy. And they may be the sole therapy for heart failure patient with fatigue and mild dyspnea on exertion. Okay, so Ernesto is an ARB, and so they have approved combination therapy, which is the newest thing. Entresto is an ARB, and valsartan these 2 drugs used in combination have a high incidence of reducing mortality in heart failure. Obviously, if they have a history of hypersensitivity to either component of drug or angioedema to an ACE or an ARB, they are not to be prescribed. It's contraindicated. So remember, before you're prescribing, as any other time, make sure you're asking about allergies or history of any other drugs that they may have had issues with, especially in treating cardiac or high blood pressure issues. Okay, vasodilators and nitrates may be used if they can't tolerate the ACE inhibitors. You want to add a diuretic if their symptoms persist or if they have a lot of fluid overload. You also want to make sure you're being very careful. You don't want to over-diurese because it can lead to hypotension and renal insufficiency. Mild heart failure, thiazide diuretics are usually used. Okay, sodium restricted diet for all heart failure patients. You want to use specific beta blockers like carvedilol, aldosterone or spironolactone for stage 3. And of course, in these particular patients, you also want to be evaluating them with the cardiologist, of course, to see if it's appropriate for them to get a pacemaker or defibrillator as needed. If the patient's in severe heart failure, then we want to consider digoxin. But if obviously you're watching their blood levels when you prescribe that. And if they're in end-stage failure, that's when we have to switch over to Intropin, Doputrex, or Primacor. We want to consider antiarrhythmics and AFib and anticoagulation. So primary care includes, exercise, cardiac rehab, of course, make sure they're up to date with their vaccinations, making sure, like, again, primary care, very prevention. It's also primary and preventative. So we're talking about lifestyle changes. We're talking about primary interventions here with vaccinations. We're talking about our dietary changes. We want to make sure our sodium is less than 2 milligrams per day. We want to make sure that patient is checking their weight daily. If they gain 3 pounds overnight or 5 pounds over a week, that's an instant call to either ourselves or the cardiologist. We want to decide if they need to be on fluid restrictions to prevent them from retaining any more fluid. We want to 100% discourage alcohol. Remember, alcohol causes inflammation. These particular patients don't need any additional inflammation in their body, obviously. We want to remove any barriers to med adherence, like cost or complex med regimes. So again, do we need help at home with managing our meds, getting a Mediset set up, getting education at home as to when to take them, and making sure they're taking them consistently. We may need to get home care services in place to help educate them at home. Good patient education sites include American Heart Association, and work with home care nursing to educate. Exactly. Psychological support for sure. We want to get these patients whatever kind of psychological support we can, because remember, this is a game changer in terms of life, and they may be coming to an end stage where they need to start considering advanced directives as well as more support at home. In this particular case, I would suggest highly, if you're dealing with patients with heart failure, you start to consider talking about advanced directives with both the patient and the caregivers. Have those family meetings, because this is the time you want to do it when the patient still has the full capacity to make the decisions that will impact the quality of their, not only their life, but the end of their life, where they deserve dignity and they deserve to pass in the manner that they would want for their own wishes. So this is the best time to talk about advanced directives. Assess their quality of life. You want to see how they're sleeping, their sexual function, mental health status, their outlook on life, their appetite, social activities, their network, and what they're doing to kind of just reduce stress and enjoy themselves. Comprehensive heart failure management can be challenging. Managed with cardiology can be rewarding and life-saving to patients, for sure. All right, that's it, guys. This was a lot of information. We will come back to cardiology next week to really focus in on the arrhythmias. So I would encourage you just to really understand these things. Look at those lab values that you need to make sure the diagnostics, those are really important, and know your guidelines specifically for hypertension and heart failure, as well as metabolic syndrome. Okay, have a great week. We'll see you next week.